Here we have a terrible triad question. A young gymnast fell. Again, form and supination. We really have been through this before, but what do you have? You have a terrible triad injury in which you have a dislocation, an injury to the radial head. And what type of coronoid injury? A type 1 shear to the coronoid, most commonly seen in the setting of elbow dislocation. This again, we're really touching again on the same points. The same points we discussed with coronoid, the same points we discussed with radial head, and the fact that now it's well understood that the primary stabilizer of the elbow is the lateral collateral ligament complex, which courses from the lateral epicondyle down to the supinator crest of the ulna. That's the money ligament providing stability to the elbow. The terrible triad we've been through again and again. Valgus, supination, rotatory injury, lateral ligament fails, radial head fails, anterior aspect of the coronoid shears off. So it's a rotation of bony and soft tissue injury. It says possible MCL disruption. When the elbow dislocates, by definition, the medial ligament tears, most commonly partial or complete tear. And again, the medial ligament is not the important part in which to address surgically. The prognosis for the terrible triad was historically poor, but I will again state that now with our understanding of reparative efforts to treat these, it's not necessarily a terrible prognosis. We always have stiffness, we always have the risk of instability or recurrent instability, but I don't think the prognosis is as terrible as it was when Bob Hotchkiss defined this term approximately 25 to 30 years ago. The radial head we heard a little bit about earlier. Why is the radial head important in a terrible triad? Well, I think of the ulnohumeral joint as a hinge. That's the medial side of the elbow. Laterally, we have the capitellum and the radial head. And when you lose the stabilizing support of the lateral radial head or the radiocapitellar joint, I think of it as a person standing on one leg. The radial head provides a lateral buttress to the elbow, just like the medial facet of the coronoid provides a medial buttress. When you have a dislocation and any significant injury to the articular surface of the radial head, we've now lost bony support laterally, allowing it to collapse. We've now lost ligamentous support, and that's why the terrible triad injury is by definition one that almost 100% of the time needs surgery. It may sound obvious, but when I trained, it was not appreciated, and now it's clearly appreciated. I remember the first time I heard this, it was almost surprising to me, but elbow dislocation, radial head fracture, that means surgery. And there are times when we try to limit extension. These elbows are most unstable at terminal extension. I will tell you that these patients often have trouble getting extension. So the issue of trying to keep them from extending more than 30 degrees is usually not a problem. Most of these individuals at 2 and 3 months are still lacking 30 degrees of extension. So I don't use much in the way of hinge braces or braces that block terminal flexion. We again use a posterior splint and work on range of motion. If you're really concerned, you go for 3 to 4 to 5 weeks supine, working on elbow extension against gravity. That will be by definition a stable way to recover mobility. We've been through again the lateral ligament failing. The medial ligament is something that was mentioned earlier. The medial ligament courses from the epicondyle down to this lateral aspect of the medial facet, the sublime tubercle. The medial ligament is really important in baseball pitchers. This posterior band is really, I think of this as the medial ulnohumeral joint capsule. I think it's just confusing to call that the posterior band. This is the ligament of the elbow analogous to the lateral collateral ligament. This is really poorly defined, this posterior aspect in the majority of individuals, and really it's unclear what stabilizing structure that has. So the most important aspect of the medial ligament is the anterior bundle, as seen here, and to me what's termed the posterior bundle is only important in the setting of stiffness, when in order to gain full flexion, you have to cut whatever is behind the axis of the elbow. You have to cut these fibers if you can't get full elbow extension once you've released the posterior capsule. You sometimes have to cut the posterior aspect of the medial ulnohumeral capsule. And again, in the setting of terrible triad, the medial ligament and the flexor pronator origin are usually not in play. They're usually not the problem. It's again the lateral ligament complex. I spent a year of my life trying to understand this, but in brief, the lateral collateral ligament originates from the epicondyle, essentially from the isometric point, which is the center of the capitellum. It blends in with the annular ligament. The annular ligament wraps around the radial head. It's one of the only ligaments in the body that begins and ends on the same bone. It begins along the supinator crest, wraps around the radial head, and inserts back on the ulna. And then you have the lateral ligament blends with the annular ligament, and they both insert onto the sublime tubercle. That's why it's termed a complex. That's the sleeve on the lateral side that imparts stability. That's the sleeve that most commonly tears off of the humerus. And that's that complex that you're repairing when you sew what has ripped off of the humerus back to the humerus in the setting of a terrible triad injury. This is not subtle. Patients have a major elbow injury. The examination is not subtle. The radiographs are not subtle. We always talk about this ASES Lopresti injury. This is an injury that is a longitudinal form disruption. The radial head fractures, and there's a force that goes all the way down through the interosseous membrane to the wrist. You should start to think about ASES Lopresti injuries when you're talking about severe high energy trauma. I've seen less than 10 in 20 years. These are falls off a 20-foot ladder. These are 65-mile-an-hour high-speed motor vehicle accidents. Any other elbow injury from a standing height or sports injuries, we always talk about this longitudinal form disruption, but it's extremely rare, and it's usually not subtle. What you see is the the radius and the ulna proximally divergent, or one more anterior and one more posterior. It's not subtle. It's something we always talk about, and it's something you probably never will see in your practice of orthopedic surgery. This is what you'll see. You'll see a dislocation, again a posterolateral dislocation, radial head fracture. If you see a piece of bone around the elbow, there's this piece, usually not the coronoid, it's usually a piece of the radial head. What's the treatment of this? 100% surgery. After you reduce this, we often get a computerized tomographic scan to better evaluate articular fracture fragments, better plan your surgical approach. And then the treatment is, of course, to replace the radial head. This is the three-dimensional computerized tomographic scan. This is really what I love. I think it's very important. You can bring this into the operating room. You can rotate around to fully understand. It shows you many times these little osteochondral fragments. When you're doing these cases surgically, you have to gap open the joint, squirt some saline in, and you'll wash out these osteochondral fracture fragments. Very important in terms of, at least we believe, in terms of long-term arthrosis of the elbow. And then we've been through this again. Most of the time you do nothing to the coronoid. Most of the time you replace the radial head, and then you repair the lateral ligament. And it says indications to immobilize, rare. I will tell you, I immobilize more commonly than not, at least a week to 10 days. And if I'm really worried, I don't even stress about keeping the elbow in a long arm cast past 90 degrees for 3 weeks. We are going for stability. We are going for a concentric joint. I don't really care about stiffness, and I don't really believe that a week or two more of immobilization is an independent risk factor for stiffness. This talks about a strengthening after 6 weeks. I will tell you, we typically begin motion when we're comfortable. All motion is done with the elbow tucked against the body. You don't want to have the shoulder abducted, as we discussed before. It imparts a varus moment to the arm and to the elbow and to the lateral ligaments. and I work on rotation only with the elbow maximally flexed to lock in the ulnohumeral joint and protect the medial and the lateral ligament from torsion or forces that would tend to distract or injure them. So here we have a core test question. 26-year-old male, fall from a ladder, outstretched hand. He has a closed injury. Here are the radiographs. I mean, you really can't have been, even if you've slept through half of this, you look up and you say, oh my gosh, another terrible triad. Yes, oh my gosh, another terrible triad. Dislocation, lateral ligament complex, treatment, lateral ligament repair, radial head replacement. Medial ligament, very rare to have to surgically intervene in the setting of a terrible triad. So again, the money ligament of the elbow is lateral. That's what fails. That's what leads to the forearm supinating away from the humerus. And that's what has to be addressed at the time you restore bony anatomy. You're restoring bony anatomy most commonly by replacing the radial head with one of the newer metallic implants. This just talks about replacement versus ORF of the radial head. It's almost always replacement. Coronoid ORF, very uncommon. LCL reconstruction, not really. LCL repair. MCL reconstruction, very, very rare. Usually MCL repair. To me, a reconstruction suggests a free tendon graft or a supplement to the collagen, usually only needed in the chronic setting, and a type 3 coronoid almost never in the setting of elbow dislocation. Elbow dislocation usually type 1, once in a while type 2, and almost never type 3. Another test question, a 44-year-old male has residual posterolateral instability when the elbow is extended. What's responsible for lateral instability? Well, we've talked about that. It's the lateral collateral ligament complex. They're showing you an x-ray here where the bony integrity of the elbow has been beautifully restored. If this elbow subluxates in extension, what you're missing is an adequate repair of that lateral ligament. The lateral ligament complex is what stops the elbow from sliding out or subluxating as we extend our joints. So again, that's what has to be repaired anytime you have a fracture dislocation of the elbow. So first thing is restore bony anatomy, usually by a metallic implant, and then you have to, of course, repair the lateral collateral ligament on the way out. I don't like posterior skin incisions. To me, the skin incision is surgeon dependent. I have no problem with posterior incisions. I usually like to go lateral for lateral problems, medial for medial problems, and I try not to deglove or strip the subcutaneous tissue away from the fascia. There's nothing wrong with a large posterior incision, but it does require you to deglove or strip the soft tissues off of the fascia. I had a lot of problems with seromas and fluid collections, and I've really gone back to the way I was taught, which was medial and lateral incisions. I think it gives you more direct access. I think it allows for less soft tissue disruption and less stripping. Radial head arthroplasty, almost always we've talked about the plate position in that safe zone. Again, it's lateral with the forearm in neutral. But when we're talking about the terrible triad, we're almost always talking, as I've said again and again, with radial head replacement. So to me, it's not necessarily ORF versus arthroplasty. It's 99% of the time arthroplasty. As Joaquin mentioned, if you have missing even 25 or 30 or 50% in the setting of dislocation, you have a potentially unstable situation. You've got to restore everything to make that elbow stable. So you have to restore the entire circumference of the radial head, and then you have to, of course, repair the soft tissue sleeve. And this, to me, this is the classic article. This is the article we have the residents read. It essentially goes through a step-by-step evaluation, treatment, and surgical plan for the terrible triad injury. And everything that I'm telling you tonight will be in that article. And again, they'll explain how the radial head has to be replaced, and the lateral soft tissues have to be repaired, and very, very rarely do you have to go medial on the terrible triad injury. The coronoid, when it's injured and when it needs to be fixed, only is in the rare situation, as I mentioned, when the fracture comes down to the 50-yard line. Rarely is this true, and when it is true, you address the coronoid most commonly after you've removed the radial head. The lateral ligaments torn, the joints unstable, you can supinate the form and look directly down on the coronoid. It's the best exposure of the coronoid you will ever have in the setting of a terrible triad injury. Again, I don't like sutures. I don't like string. I like screws, or I like small little buttress plates. I have used with smaller fragments pins, just smooth or threaded Kirschner wires. You can cut these flush. Again, you're just trying to put back that anterior buttress, and then you repair the lateral side after you've replaced the radial head. And if you've only used pins, for example, you only used a couple threaded 6-2 Kirschner wires and you've cut them flush, okay, so you immobilize the elbow 3 or 4 weeks until the bone has a chance to heal, the soft tissue has a chance to begin to heal, and then you start motion. The goal is a concentric joint. I can't say it enough. The lateral soft tissue sleeve can be repaired by whatever technique you'd like. You can repair the lateral sleeve with a bone anchor into the humerus. We tend to like running, locking transosseous sutures that come through the humerus, tied over the posterolateral column. It's just because I think it's easier to tension and bring tissue to bone by transosseous sutures than it is to push tissue to bone, to try to push the tissue back to the bone using a bone anchor. But I have no problems with bone anchors. I use bone anchors around the humerus, and in really unstable situations, we have one tomorrow, I don't hesitate to place running locking stitches through the humerus in a transosseous fashion and add a bone anchor. Try to do pants over vest or a double soft tissue repair. Again, the lateral sleeve is very important as part of any type of terrible triad repair. We've been through this again. MCL repair almost never needed in this particular clinical injury. And in the acute setting, I think the need for a static or a dynamic fixator is very unusual. If you're really worried, you can immobilize the elbow past 90 degrees of flexion, but I don't think I've ever used a static frame or a dynamic frame in the setting of an acute terrible triad injury. Usually if you replace the radial head, if you have to fix the coronoid, once you repair the soft tissue sleeve medially, rarely again medially, but for sure laterally, you almost always are rendered with a stable situation intraoperatively. So here we go, another test question. 42-year-old male injures their elbow 4 weeks ago while skiing. The most common complication of this injury, what is this injury? It is some type of periarticular fracture of the elbow. What's the most common problem with any periarticular fracture of the elbow? Well, we've been through that. It's stiffness. Stiffness more than anything else. Stiffness is the problem. But again, as long as the joint is concentric, I don't consider stiffness a bad complication. As long as the joint is reduced and concentric, stiffness is a fixable complication. It's the non-congruous elbow joint, it's the unstable joint that's the problem. Stiff, stable is not, to me, a problem. So the reduced motion is the most common complication following a terrible triad. And again, I would much rather a stiff joint than an unstable or a joint that is not congruous throughout whatever mobility you have. The complications we've sort of beaten to death. Instability, most commonly due to an inability to repair the original structures, or at least appreciate the original structures. Internal fixation, most commonly you're talking about a radial head implant and a soft tissue repair. Of course, post-traumatic stiffness. Heterotopic ossification is risk based on the severity of the injury. Again, about 3 out of 100 of simple dislocations and up to 30% of the fracture dislocations. And in the setting of an elbow fracture or dislocation, there's always risk for post-traumatic arthritis. And in the setting of dislocation or terrible triad, we think that as the ulnohumeral joint dislocates, even if there's not a significant articular fracture that we can see, there is a shear injury to the cartilage. And when you treat the terrible triad fractures surgically, as I said, when you irrigate, invariably you get some small osteochondral fragments that drain out of the joint. So post-traumatic arthritis is again a risk due to articular injury. Even if you have a concentric joint, there is risk for post-traumatic arthritis, again thought to be due to chondral injury or cartilage shear at the time of the original dislocation.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.